Good morning, everyone. My topic for today will be on class 3 malocclusion and its management. Now, as an introduction, class 3 malocclusion is often considered an easy one to identify, but kind of a difficult one to treat. So, it basically represents a pre-normalcy condition where the mandibular arch is in a mesial relation to the maxillary arch. So class 3 malocclusion finds highest incidence in Japan and Korea. So these are the areas where class 3 malocclusion is more prevalent. So Edward H. Angle, he had defined class 3 malocclusion as a condition wherein the mesiobuccal cusp of the upper first molar occludes between the mandibular first and second molars. As you can see in the picture below, the first picture represents a normal jaw alignment wherein both the jaws are in normal position and the molar relation is in a class 1 molar relationship. In the second picture, we have a class 3 malocclusion scenario wherein the mandible is in a mesial relationship. The mandibular arch is in a mesial relationship to the maxillary arch. And as you can see, the molars are mesially moved. What are the classical features of a class 3 malocclusion? So in this type of malocclusion, the patient will be normally having a class 3 molar relationship in which the mesiobuccal cusp of the first molar will be occluding between the embrasure area between the mandibular first and second molar. That will be the normal class 3 molar relationship. So in this situation, the incisors may be in an edge-to-edge relationship and maybe an anterior crossbite will be occurring. So in a class 3 patient, the upper arch is frequently seen as a narrow, crowded and short, while the lower arch is usually broad. So class 3 malocclusion in vertical growers will be exhibiting an increased intermaxillary height and may have the presence of an anterior open bite. So you can see that these are some of the features of the class 3 malocclusion. In the first picture, there is an anterior crossbite present. Second picture, there is a posterior crossbite present. It is mostly due to the fact that a wider part of the mandible will be occluding with a narrower part of the maxilla due to the reason that the mandible has a mesial relationship. In the third picture, you can see the profile view of a typical class 3 patient wherein there is a concave profile due to a prognathic maxilla or a mesially placed mandible. So let us talk about some of the skeletal features of the class 3 malocclusion. So most class 3 malocclusions are usually associated with an underlying skeletal mal relationship. So some of the commonly seen skeletal features of class 3 malocclusion are a short or a retrognathic maxilla, or a long or a prognathic mandible, or a combination of both a retrognathic maxilla and a prognathic mandible, as seen in the pictures below. So coming to the etiology of a class 3 malocclusion. So there are various etiology for class 3 malocclusion. The first one is some environmental factors such as postural habits, mouth breathing habits. So postural habit may be a habitual forward positioning of the mandible due to occlusal prematurities, or an enlarged adenoids may result in a class 3 malocclusion. So if the patient is having a severe class 3 malocclusion and it may have been believed to be caused due to certain genetic factors. So these genetic factors will be already there in the patient's but they may have been increased by certain environmental factors or made worse by these environmental factors. So there are environmental factors, genetic factors, postural habits of the patient, if the patient is having any mouth breathing habit, or a habitual forward positioning of the mandible due to various hindrances, such as if the patient is having enlarged adenoids or occlusal prematurities. So these are some of the etiology for class 3 malocclusion. So coming to the diagnosis of a class 3 malocclusion. So all the diagnostic procedures for a class 3 malocclusion should help in the determination of the type of the malocclusion. If the class 3 malocclusion is a dental or skeletal one, or if it is a true or a pseudo class 3 malocclusion. So initially the patient should be thoroughly examined by virtue of clinical examination, and also observation of the path of the closure of the mandible should also be noted. So we can take use of study models and various radiographs to study the type of the malocclusion. So when coming to the radiographs, we have lateral cephalograms and orthopantomograms, which offer valuable information on whether the malocclusion is skeletal or dental in nature. So normally the patients with class 3 malocclusion often have a family history of other people having an anterior crossbite or a class 3 malocclusion. When coming to dental class 3 malocclusion are characterized by a lack of sagittal skeletal discrepancy. In this case, the ANP angle will be somewhat normal. This dental problem alone will be caused by labial tipping of the mandibular incisor and lingual tipping of the maxillary incisors. So patients with skeletal class 3 malocclusion usually exhibit the following features. So they would be having a smaller than normal SNA and a larger SNB angle. So this in turn leads to a large negative ANB angle. Also, maxillary incisor will be proclined and retroclined mandibular incisor will also be present. So coming to pseudo class 3 malocclusion, this usually happens due to a functional shift. So there will be usually a COCR shift, that's a centric occlusion and centric dilation shift, the variation between these two as a result of abnormal tooth complex, which ultimately leads to a forward shift of the mandible on closure of the mandible. This in turn gives an impression of a class 3 malocclusion. So coming to the treatment modalities of a class 3 malocclusion, this type of malocclusion should be recognized and treated early due to the following reasons. That is, early interception reduces the severity of the developing malocclusion, and malocclusion characterized by anterior crossbite often result in a retarded maxillary growth due to the locking of the maxilla within the mandible. So in this case, the occlusal forces on the mandibular incisor exerted by the maxillary incisor in crossbite encourages the continued forward growth of the mandible, which further worsens the prenormalcy or the class 3 malocclusion. This is the flow chart regarding the treatment of the class 3 malocclusion. So we have the class 3 malocclusion for a growing patient and a non-growing patient. So in a growing patient, they will usually have a skeletal class 3 or a dental class 3. So for a skeletal class 3 in a growing patient, they'll usually be found out with maxillary retrognathism, mandibular prognathism, and maxillary retrognathism, or a mandibular prognathism alone. So for maxillary retrognathism, we will usually give face masks for protraction of the maxilla. For mandibular prognathism and maxillary retrognathism, we will be usually giving face masks followed by chin cup or by usage of myofunctional appliances for correction of the malocclusion. So in case the patient is having mandibular prognathism alone, we will be just giving chin cup therapy to restrict the growth of the mandible further. So when coming to dental class 3 malocclusion in growing patient, we'll be putting them forward with the orthodontic treatment as per needs. So in a non-growing patient who is having a class 3 malocclusion, they have in turn divided them into dental class 3 and skeletal class 3. For a dental class 3 malocclusion in non-growing patient, we'll be providing them with orthodontic treatment as required by the law. For a skeletal class 3 malocclusion for a non-growing patient, they will be either be having a severe skeletal class 3 malocclusion or a mild to moderate skeletal class 3 malocclusion. the patient is having a mild to moderate skeletal class 3 malocclusion, will be usually provided them with orthodontic camouflage by extraction of some teeth. So camouflage usually means extraction of the lower premolars and then retraction of the lower anterior, so that the severity of the skeletal class 3 malocclusion is reduced. If the patient is having a severe class 3 malocclusion, then it in turn can be divided into maxillary retrognathism or mandibular prognathism, or a combination of these two. So we'll be providing them with treatment modalities such as surgical maxillary advancement for maxillary retrognathism, and for mandibular prognathism, surgical mandibular setback, or a combination of these two. So how do you intercept the class 3 malocclusion during growth periods? So during growth periods, it might be required for an early interception of the class 3 malocclusion to prevent worsening the class 3 into a skeletal class 3 malocclusion, and further requirement of surgical procedures may be avoided. So the aim of such a type of treatment is to improve the skeletal discrepancy, thereby providing a more favorable environment for future growth. It also helps in eliminating or reducing the chances of orthognathic surgeries in the future. So by intercepting class 3 malocclusion during growth period, we can prevent the patient from undergoing further surgical procedures in the future once the growth is complete, and then we can save the cost and the timing and the other related factors for the patient. So indication for interception of the class 3 malocclusion during growth periods are when if the patient is having good facial aesthetics, if the patient is having an anterior posterior functional shift, if he or she is having just a mild skeletal problems, or if there is any absence of familiar prognathism, the patient is having a convergent facial type, if the condylar growth of the growing patient is symmetric in nature, and most importantly, if the growth is still present for the patient, or still remaining growth is there for the patient, this we can like check by using lateral cephalograms or hand wrist x-rays. And finally, if the patient is cooperative enough for interception of the class 3 malocclusion, the patient is uncooperative, it will be difficult for us to intercept the class 3 malocclusion by virtue of any myofunctional appliances, or by using chin cup or face mask therapy. So contraindications are poor facial aesthetics, absence of anterior posterior functional shift, familiar prognathism, divergent facial type, severe skeletal problem, and an asymmetric condylar growth. And if the patient does not have any type of growth potential remaining in them, and if the patient is uncooperative. So what are some of the techniques used during growth period to intercept the class 3 malocclusion? So there are various usage of few appliances. So the first appliances will be myofunctional appliances. In myofunctional appliances, we have the FR3 or Frankel 3 appliances. So FR3 appliances can be used to intercept a class 3 malocclusion if it is due to maxillary skeletal retrusion. So it basically incorporates vestibular sheets in maxillary and mandibular arches or the sulcus. So the maxillary shields are placed away from the buccal plate, thereby stretching the periosteum and allowing the forward growth of the maxilla. When coming to the mandibular shields, it is usually placed touching the alveolar process, and therefore it helps in restricting the further growth of mandible. So FR3 appliances also are able to produce a dento-alveolar effect by proclining the upper anteriors and retroclining the lower anteriors. So finally, it can also be used as a retainer after face mask therapy. So next is usage of chin cups to intercept a class 3 malocclusion. So chin cup therapy is usually used in treatment of class 3 malocclusion with protrusive mandible and a normal maxilla. So the two types of chin cups which are commonly used are occipital full chin cup and vertical full chin cups. So the main effects of the chin cups are there will be a backward repositioning of the mandible, which in turn redirect the mandibular growth. Remodeling of the mandible with closure of the gonial angle. So chin cups with headgears are indicated in primary and mixed dentition periods, and the force levels will be around 300 to 500 grams per side, and the patient is requested to wear the appliances for about 12 to 14 hours every day in order to bring about the significant changes. So coming to face mask therapy, the face mask is also known as reverse pull headgear, and it is usually used in treatment of mild to moderate skeletal classroom malocclusion when it is due to retrognathic maxilla and hypodivergent mandible. It consists of two pads, okay, which take anchorage from the forehead and the chin. So there will be two pads, one in the forehead, one will be propped against the chin, and then these two pads will be connected together by a midline wire frame that also incorporate hooks. In these hooks, we have elastics anchored to it, which stretch from an intraoral splint, maxillary intraoral splint, which helps in the protection of the maxilla. So there will be a forward and downward growth of the maxilla once this reversible headgears are given. So as you can see the picture below, this is a photo of a face mask or a reversible headgear. So the intraoral spring in the reversible headgear can include an expansion spring. If expansion of the maxillary arch is required, usually some expansion will be required due to mandible being prognathic and the wider part of the mandible occluding against the narrower part of the maxilla. So in case of face mask, it is also used for primary and mixed dentition periods. So like before, the force levels for face mask is almost about 300 to 500 grams per side and are indicated for 12 to hours, 14 hours of wear every day. So coming to commonly used type of face mask, they are the Delaire, Tubinger and Petit type of face mask. So how can we correct classroom malocclusion using fixed appliances? So it is best done in mixed dentition period before eruption of the permanent canines. In patients with mild to moderate class 3 skeletal pattern, a combination of retroclination of the lower incisor and proclination of the upper incisor is usually done. So class 3 intermaxillary elastic traction from the lower labial segment to the upper molars can also be used to move the upper arch slightly forwards and the lower arch slightly backwards, and helps in correction of the class 3 malocclusion and also helps in better interdigitation of the occlusion. But in this case, care has to be taken in order to prevent severe extrusion of the molars, which can reduce the overbite significantly. So how do we treat an anterior crossbite? So mild anterior crossbites in class 3 malocclusion can be treated by using a lower anterior inclined planes or a removable appliances incorporating screws for anterior expansion. So just like anterior crossbite, there will also be posterior crossbite present. So usually by virtue of rapid maxillary expansion, posterior crossbites can be managed. So how does the role of extraction helps in correcting class 3 malocclusion? So when the class 3 malocclusion is characterized by mild mandibular prognathism, in this case, the lower arch crowding can be treated by extracting the lower first premolars, followed by a fixed mechanotherapy. As I said before, this is also termed as orthodontic camouflage for an underlying skeletal class 3 malocclusion. So how do we treat a severe class 3 malocclusion? So severe class 3 malocclusions after the growth completion is kind of difficult to treat, but it can be tackled by surgical procedures. So class 3 malocclusion due to maxillary deficiency is usually treated by maxillary advancement procedures such as Lefort 1 or osteotomy. When the malocclusion that are there as a result of mandibular prognathism are treated by mandibular setback procedure. If class 3 malocclusion has a combination of mandibular prognathism and maxillary retrognatism, it is tackled to combination procedures, that is mandibular setback and maxillary advancement. So as I said before, there is another type of class 3 malocclusion known as pseudo class 3 malocclusion. This is due to habitual forward positioning of the mandible due to some kind of occlusal prematurities. So when these occlusal prematurities or any other cause that causes habitual forward positioning of the mandible is removed, then it leads to the correction of the pseudo class 3 malocclusion. Thank you.